webinar, part one of our Men's Health series, Restoring Testosterone Naturally, featuring Dr. Brandon Lundell. Today's session covers the male hormonal crisis demystified, and part two, Restoring Optimal Testosterone Function Naturally, goes live Wednesday, March 25th. My name is Sally Lynch, VP of Marketing at Biotics Research Corporation. Before we begin, just a quick reminder, all of our webinars are recorded and posted to the Biotics Research website within 24 hours. If you have questions during the presentation, please type them into the Q&A box and we'll address as many as possible at the end of the session. We're excited to have Dr. Lundell with us today. Dr. Lundell has been practicing and teaching integrative and functional medicine for over 2 decades. His approach empowers patients by uncovering the cellular, dietary, and lifestyle origins of chronic disease. Using advanced laboratory medicine, thorough physical examination, and detailed patient history, he identifies exactly what is happening in the body and why. Not just matching protocols to symptoms, his guiding principle is simple. Good doctors know what to do, and great doctors know why. That philosophy drives both his clinical practice and his teaching. Dr. Lundell is the founder of the Nutritional Pathology Institute and has trained over 1,000 licensed healthcare practitioners through his certification program in functional medicine. He has served as adjunct professor at Southern California University of Health Sciences and teaches for several organizations throughout the country, including the Council on Diagnosis and Internal Disorders. His work has been published in peer-reviewed publications and health periodicals. Welcome, Dr. Lundell, and thank you so much for joining us today.
All right, thank you, Sally, and thank you, Biotics, for having me. Yeah, this is a two-part series because there's too much information to put in one webinar. So I wanted to cover this in the way that it deserves, and we'll be touching mostly on male hormones, but we'll touch also on female hormones a little bit as well. But really, the purpose of this for me is that I have been in practice for 20 years, and this disturbing trend in the last 5 years or so is just seeing more and more patients coming to me on testosterone, both men and women, and they might feel better at first. Someone put them on testosterone, but then invariably it stops working, or they have to do more and more and more. And when we actually do proper testing, which we'll learn about today, they're being so overtreated, and there are a lot of dangers that go with this. And there's a better way. Ultimately, there's a better way to do this, and it's really actually not that hard. But from a functional medicine standpoint, we have to go through functional endocrinology and support our patients so that they actually feel hormonal health for the rest of their life. There's no doubt that there is a crisis. So we'll go through that today, and we need more practitioners who know how to do this, because the problem is only going to get worse, and we're seeing the problem only getting worse. So standard disclaimer there. So this is part one. What is the testosterone crisis? We'll talk about that because it's real and it's out there. It's really a hormone crisis in general, but we're going to talk about testosterone mostly today. Why are we seeing such a recent and dramatic shift, not just in testosterone levels, but in testosterone function? We'll talk about proper testing methodology. What I can tell you is almost no one who's doing exogenous hormones is testing correctly. It's like looking at a field when you're trying to find something inside a house. You're not looking at the right place. So blood testing has its place, but we'll talk about why, when you're doing exogenous hormones, blood values are almost irrelevant. And no one knows this, seems to know this and understand this. So we'll talk about it. Restoration versus replacement. Is replacement of hormones really the best we can do? What about restoring proper function, right? Proper use of testosterone if it's warranted, and we'll go through the treatment options. We'll touch upon them today, but today what we're going to do is lay the foundation for actually then what do we do with cases that come into our office, and that'll be part two, which will be in March 25. March 25th. So We'll talk about the diets that actually work for healthy hormones and hormonal health, lifestyle, nutraceutical interventions. We'll touch upon that today. So you'll get some clinical action steps and things you can take away today. So don't worry, it's not all theoretical today. We'll talk about more testing methods in part 2, and then we'll dive into the case study. So I hope you can make part 2. And if not, it will be recorded. So, just make sure you're signed up, and I'm sure Biotics will make sure that you get part 2. But of course, if you come live, I always give some special deals to people who come live, and you get your answers, get your questions answered as well. So we'll do one case study, 35-year-old male, and more young males are being put on testosterone, and he was iatrogenically induced with hypogonadism, so it actually made him a lot worse, and he was severely overtreated. No real diagnosis as to what was happening. They just ran a testosterone level that was 250 and said, well, he needed to be on testosterone. So we'll go through within 4 months of what we're going to talk about today and what we'll implement March 25th. Within 4 months, he was off all of his testosterone, and he was producing more testosterone than what he was actually taking. So this stuff really works. This is why I want to get it out there. This works, and more practitioners just need the tools, need the skills to do it. So what we're going to learn today is functional endocrinology principles, and this is the foundation for being able to treat not just males but females as well. Understanding the difference of just running blood levels versus understanding where the problem is. We'll define the crisis, we'll examine the real causes, identify the limitations, potential dangers of conventional TRT, and really, how do we restore the hypothalamus, pituitary, adrenal, and gonadal axis, because it all goes together. So first I want to say, let's take a 30,000-foot view. Male health, and female health for that matter, it's not about hormone levels. We get so overfixated on just the level of testosterone, or the level of hormones in the blood or urine or saliva, whatever you're doing. We're so much more than that. Obviously, this is a key component of health and how we function, but we as human beings are so much more than just our testosterone level. So it's always good in functional medicine to remind ourselves of that, remind our patients of that, because it really will drive how we see our patients and how we treat them and how we guide them back to health. So we'll focus on testosterone a lot today, but just remember, it's treat the patient, not the labs. And as Sally said, I teach functional medicine through nutritional pathology. You can go to drbrandonlundell.com to learn more. One of my sayings is, a good doctor knows what to do, but a great doctor knows why. Why is this happening? And why do these treatments work, and why do they fail? So a good doctor knows what to do. I can give you a protocol in 5 minutes, but a great doctor knows why. So my focus, my passion is to make a lot of great doctors out there. The other thing that I say is that, we want to test and not guess. Okay, so lab testing becomes very, very important in what we do, but also treat the patient and not just the labs. So while TRT might temporarily relieve symptoms, it typically doesn't address all of these underlying things that we'll go through today. It ignores the metabolic, endocrine, lifestyle factors. So that's what we're going to do today. So let's start the functional endocrinology journey, the journey of hormones. Let's kind of go back to school just for a second and remind ourselves of how hormones really work, because it seems as though many practitioners either never learned this or they forgot it, and in any case, we can all use a refresher sometimes. But understanding that endocrinology, hormones don't act in isolation, right? Hormones is actually the context of the interplay between the environment, the neuroendocrine system, the immune system, the mitochondrial, the gastrointestinal system. The hormones don't act in isolation. All of the hormones that we produce in the body are both produced in cause, by the effect of what's happening, and they also cause a change in all of these environments. So So the first principle is hormones are the harmony of the body. There's no doubt. Hormones are a way our bodies communicate and our cells communicate. So by definition, a hormone is a biochemical compound that is secreted in one tissue and either sends a cell communication within that tissue, that's an intra-hormone, or paracrine or endocrine to sends the signal to a far off endocrine or a far off tissue. So we don't want to just replace hormones. We want to repair that whole system of cytokines and interleukins and hormones because they all, and peptides, they all play together in the same sandbox. So the first treatment really to employ is lifestyle medicine, because lifestyle issues is typically what is one of the main drivers of endocrine dysfunction, right? So we're talking about diet and exercise, stress reduction, all of that plays a role in why we are where we are today. So it's not just about even a hormone or even a supplement. It all has to fit in to diet and lifestyle and biochemical nutraceutical interventions. So and when it comes to bioidentical hormone, even if we do need it, doing this allows those hormones to work better with less side effects, and the patient ultimately has to use less if you're testing correctly. So why are there so many endocrine problems? Well, really, we're talking about from womb to tomb. Endocrine disruptors have affected our gonadal development for close to 100 years now, and many books have been written. My favorite book on this topic is Our Stolen Future. Still one of the best books written in the 21st century, and it's talks about how endocrine disruptors, how they discovered endocrine disruptors, and how it affects fetal development. And those changes in the womb last a lifetime. We'll talk about a book called Countdown. So kind of the next book, right? The sequel to that, Our Stolen Future, is Countdown by Shauna Swan. She's a PhD researcher, and she's been studying hormonal health from womb to tomb her whole career. And so it's a great book called Countdown. Two books that if you treat hormones in your practice, you should absolutely pick up and read. These are also important if you're doing fertility, because preconception is one of my favorite things that I do in my practice. And if it's not just about getting pregnant, it's about making sure that the baby develops optimally. So endocrine disruptors, we all know, plays a big role in all of this. But what do we do about it? We can't live in a bubble, and even if we did, that would probably be worse for us if we did. So there's ways in which that we can not avoid everything, live a cleaner lifestyle, but also how do we mitigate the exposures that we all get from day to day, and we'll go through some of those today. Obviously, being overweight, obesogens, inflammation, how it affects the microbiome and leaky gut, huge driver, which we'll talk about today a lot. The gut gonadal connection is something that is only recently really coming to light, and understanding how to leverage the gut gonadal connection. Oxidation, inflammation, nutritional deficiencies such as methylation, mitochondrial effects, sleep and recovery, lack of belonging, quality relationships. One of my favorite books is The Good Life, which was, I think, written a couple years ago, and it's a summary of the Harvard health study, the longest human study to date. It's in its 10th decade, looking at the factors that actually creates longevity and health. And guess what? It's not just being in the gym and being muscle bound. It's actually, which is pretty popular these days, but it's actually belonging and quality relationships. So we can't forget those kinds of things too, even as we love our biochemistry and we love our functional medicine. So the journey of hormones here, the first part that we'll start with is the production and secretion. Okay, yes, this is based on neuroendocrine regulation, sensitivity and feedback loops, This is only looking though at endocrine gland function and hypothalamus pituitary function, the feedback between the two. And guess what? This is where most practitioners stop, okay? Is just looking at how much is in the blood. This is only one part of the hormone story, and there's actually 9 parts to functional endocrinology. But I'd like to ask everyone, where are hormones made? Obviously, the answer is right there, but hormones are made, you know, whether you're talking about the adrenals or ovaries or the testes, hormones are made, they're put together, they're packaged in the endoplasmic reticulum, which is one of the areas in the cell that is the most susceptible to oxidative damage. So that is going to be a common theme that we will talk about. Oxidative damage is what drives most glandular dysfunction, right? So when we're looking at levels in production, oxidative stress. So that means mitochondrial function is imperative to hormone production, because without mitochondria, we don't create the ATP that the endoplasmic reticulum needs to make the hormones. And we'll talk about the gut microbiome, very overlooked factor in endocrine abnormalities. But then we have this whole nother aspect called transportation, looking at sex hormone binding globulin, thyroid binding globulin, albumin, looking at how hydrated a person is. Making a hormone, the definition of a hormone means it needs to get somewhere to act on the tissue it's meant to act on. So, you know, testosterone in the testes is great because it drives more sperm production and more testosterone production, but testosterone is needed throughout the whole body. So looking at the factors that affect sex hormone binding globulin, which we'll talk about today as well. Interestingly enough, a little clinical pearl, because I throw these in here that aren't always in the notes. That's how I teach. I always like to give the people who are attending live a little bit extra. But a lot of people think that diindolylmethane is an aromatase inhibitor, and it actually isn't. And in some cases, diindolylmethane can increase sex hormone binding globulin and therefore actually decrease the free fraction of the hormone. So just a little clinical pearl that males, a lot of males don't need diindolylmethane. It's not actually, there are better aromatase inhibitors, which we'll talk about in part 2. But one of my favorite is grapeseed extract. It's probably the most studied in terms of aromatase inhibitors. But there's lots of things that we can do to increase or decrease sex hormone binding globulin, because too much is not good because it binds all the hormones, but not enough is not good either, because then hormones can actually be more dangerous at that point. So, but then we also have these pre-receptor enzymes such as the 5-deiodinase or the aromatase enzymes. These pre-receptor enzymes have to prepare the hormone for receptor docking, okay? Then we have the receptor itself, and lots of interventions, you know, selective receptor modulators or SRMs, that's, you know, tamoxifen, things like that. A lot of medications, pharmaceuticals target the receptor, but there are a lot of nutraceuticals that target the receptor function. And that's what we have to leverage, is not just the production, but all of these things. How do we modify and how do we optimize the transportation, the pre-receptor, the receptor, and then the post-receptor translation of the hormone. Hormone docks to a receptor. The receptor creates a phosphorylation cascade and enzymes that are activated inside the cell. All of those machineries need to be there and present. And that's where we get into oxidative stress. Usually oxidative stress affects the post-receptor translation, but also cofactors. Cofactors. What are cofactors? Cofactors are the necessary vitamins and minerals and nutrients for the hormone to actually work, okay? So then we have the translation, which is usually some form of gene activation. So that means the genes have to be functioning properly. And then the transcription of the that gene. So the gene is activated by the hormone, then that gene creates an RNA. The RNA goes into the endoplasmic reticulum and has to actually produce the peptide, or the fatty acid, or whatever it's producing. Usually it's an enzyme or a structural protein. So that translation has to be there. Then we have self-regulation, counterbalancing effects, signal modification, stop genes. So histones and methyl groups, they all have to be there in order to self-regulate the hormone. Then we have detoxification and biotransformation and elimination. So that's, again, glucuronidation, methylation. We have to have the lymph moving. We have to have the gallbladder functioning. All of that has to be there. We have local degradation, and then we have hepatic phase 1 and phase 2, and finally elimination. So, biliary, GI, and urinary. So I ask you, is hormones just as simple as looking at a blood or saliva test and saying, you need DHEA, or you need progesterone, or you need testosterone? Hopefully, now that we're just a few minutes already into this, you understand that, oh, okay, this is not that simple. We need to be able to assess the whole person and the whole biochemical cascade, and this is functional endocrinology. So I have a certification course, and I spend 2 entire modules, 25 hours on hormones, because to do it right, it's in modules 4 and 5. To do it correctly, we really want to understand what we're doing, and that's why when you understand this, you can turn anybody around, whether it's a pregnant mom or a couple that's not conceiving well, making sure that the gonads and the endocrine system is developed correctly in the womb, so that kid has a shot at healthy hormones throughout its life, and then all the things that we can do with diet and lifestyle and supplementation to optimize that at any stage of life. Okay, so hopefully this is just a little bit about SERMs. Tamoxifen can be antagonistic to breast estrogen receptors, but agonistic to bone and uterine estrogen receptors. What some of my favorite receptor modulators are curcumin, resveratrol. These can modulate, sensitize the receptors, but make sure that they're not oversensitized as well. So we'll get more into that. Okay, inflammatory chemicals like NF-kappa B, IGF-1, IL-6s, all of these can either antagonize or agonize certain proliferative effects of the hormone. So the inflammatory milieu of the cell is paramount for making sure that the hormones function properly. So the final thing that I want to get into before we dive into testosterone specifically is this all-important, critically important concept of receptor modulation, self-receptor modulation based on hormone concentration. So this is something that is in every textbook, but it must be forgotten as soon as we take boards. As concentration of hormones increase, cells will respond by decreasing the receptors. The converse is true, where when we don't have enough of the hormone, the receptors will upregulate. Okay, this is our body's tremendous adaptation for fluctuating hormone levels. This is why I've seen TSHs in the 150, and people are still functioning. You think there's no hormone that they're producing, how are they even living? And they're actually doing okay, not long term, but they're not just in bed, comatose, because this is one of the mechanisms by which the body can adjust and self-regulate. This is forgotten when we over-treat with exogenous hormones, because almost to a person, they're over-treated with hormones, and these cells respond by down-regulating and desensitizing. And so then patients are stuck because they can't get off of it. Then if they remove the testosterone, then their cells are actually they're resistant. It's essentially creating a testosterone resistance. So this is what happens, and this is what I see. And it usually takes about 6 months to get out of a hormone resistant, 3 to 6 months, depending. Okay, we'll talk about laboratory tests more in the second one. But what I will say here is that you can test free or bound levels, but testing free and total testosterone, remember that's still in the blood. Okay, so let's go back to functional endocrinology. When a hormone is produced, it gets put into the blood because that's the transportation mechanism. Do hormones actually have any effect in the blood whatsoever? No. There's no receptors in our cardiovascular system for actual hormones. Very little. Not in the cardiovascular inside of the intima itself. So hormones in the blood is relatively, it doesn't do anything in the body. Where do hormones actually create their effect? It's in the cellular environment, so outside of the blood. And hormones will accumulate, especially if you're giving them, through creams or shots or troches, sublinguals. Anything that's parenteral will build up in the peripheral tissues, and the blood levels will not reflect that. Sometimes I've seen, and the literature shows, that tissue levels can be a magnitude of 20 times higher in the peripheral than in the blood. And yet practitioners still only look at blood when they're assessing dosages. And this is wrong and it's harmful. And so what we have, and urine isn't a whole lot better, because urine is essentially what's in the blood, because it's just all the metabolites that are in the blood. So other than doing a tissue biopsy, what we need to do is saliva hormone testing, especially if you're giving someone exogenous hormones, parenteral hormones, okay? And then we can also, though, look for the downstream effects. So as an example, hemoglobin A1C is more important than glucose or insulin by themselves. Serum electrolytes give you a clue as to what the adrenal glands are doing. Cholesterol and MCV, those are indicators sometimes of hypothyroidism. So looking at the downstream effects of hormones is really important. So that's why we do the saliva. We do blood, urine, and saliva, and they all have their place. We often do blood at first just to see what the production is like, but certainly we almost always do saliva in my practice if we are seeing that they're on exogenous hormones. It's also a great way to look at the adrenal glands, because you're looking at 4 or 5 samples in a day, and that's very hard to do with blood testing. So amino acids, organic acids, all of those can give you an idea of how the hormones are acting in the body. Okay, the state of male hormonal health. In a word, good. In 2 words, not good. In 3 words, not good enough. Okay, so we have a long way to go to optimize testosterone, and it starts in utero. As we will see, it starts in utero, but testosterone levels have been dramatically declining. This is nothing new. I'm not telling you anything you don't already know, but I'm going to quantify it a little bit more, and that actually might be something that you don't know. So population level decline in serum testosterone levels in American men. What we can see, multiple cohort studies confirmed a generational decline. A landmark study in the clinical endocrinology metabolism found that testosterone levels have been steadily decreasing independent of age and health status. So BMI, yes, it's correlated to testosterone levels, but even when we remove those factors, testosterone levels continue to decline. For example, a 65-year-old man in 1987 had significantly higher testosterone levels than a 65-year-old man in 2004. This decline, though, is attributed to what the authors say as yet unknown, but we do know. But environmental toxins, lower nutritional status, insulin resistance, in utero effects of environmental factors, what Shauna Swan calls, it's the gap, between the anogenital distance, the gap between the anus and where the genitals start, and that gap is a direct measure in newborns of the pretty much the lifetime production of hormones, testosterone specifically, that person, both male and female, is likely to experience. So when there's more endocrine disruptors that affect testosterone in utero, that anogenital distance shrinks. And she's been measuring this now for 3 decades, and they are continuing to decline. So, we'll get to that. Age-independent secular testosterone populational trends among Brazilian males. This was done in Brazil. They looked at males 2010 to 2017, and the decline was actually more pronounced in younger men aged 40 and below. So, they were at 2.5%, per year. So, this is not just older men having a problem. 20% drop in just 7 years among the same age group. Okay, not the same man 7 years later got a 20% drop. The same age group, the same health of a man was 20% lower in just 7 years. And this is back in 2017. Now, we're 9 years later and it's getting worse. It's actually exponentially worse. Okay. So previous studies before 2017 thought it was about 1% per year. Now we're seeing about 2 to 2.5% a year. So this is another longitudinal study of U.S. Air Force veterans over a 20-year period. And this study also observed that the decline of testosterone was independent of age and weight. So there's something else going on. So obesity, while it is an important factor, when a person becomes overweight, it accelerates testosterone loss, but it does not drive primary testosterone loss. So this is obviously going to affect infertility as well. So we would expect to see rising infertility rates about the same rate. And sure enough, we see, remember, half of all infertility problems is male derived, not female derived. So it's amazing to me how many couples come to me for infertility, and the female's gone through all of these tests, and the male's sitting back drinking his whiskey, being like, well, I don't know what's happening, you're the problem. So, and even a traditional sperm count is not going to uncover the damage to the DNA. So you need an oxidative stress. You need to look at the DNA damage on the sperm, because that's going to cause infertility, not just sperm counts or motility. Those are helpful, but it's actually the DNA damage, the oxidative damage on the sperm. So, and I use a mail-in test. There's many companies out there. I like Legacy. Legacy is a good company. It's expensive. It's like $500 to look at the sperm count and motility and the oxidative damage, but practitioners can set up a count and give 20% off to their patients. But yeah, between 2015 2019, 11% of men aged 15 to 49 reported some form of infertility, and that's actually now, and this, because this is 2015 to 2019, the latest study I saw was about 30% of males now, and that's only been in 7 years. So we're reaching a crisis level. When you read about fertility among all species, humans have always produced the least amount of redundant sperm. Most mammals, males produce 3,000% more sperm than is needed to actually continue fertility. Males have only the highest we've ever seen in testing in the last 150 years that the last sample was actually tested, is only about 300%. Human males have always produced less. So it means that we have less leeway, and we're the first indicator species to probably be infertile, given what we're doing to our environment and our food supply and everything. So just another study. This was 2022, 51% decrease observed between 1973 and 2011, and then that's continuing to go. And the research, it's the shrinking testicular volume at birth that is creating this transgenerational setup. It's not just what's happening after birth, it's what's happening in utero, setting our kids up to have lifelong hormonal problems. What can we do about it? You know, stay tuned. There's a lot that we can do about it, but we have to do something about it now. And this is Levine. They did a 2017 and then a follow-up 2023 study in Human Reproduction Update, and that's why we're saying in just those 6 years, they saw the rate is accelerating 1.4% a year since 1973, but then since 2000, it's 2.64% decline in sperm count since 2000. So that's almost doubled, and it's doubled now in 2025. So the rate of decline is doubling, and we're already 62.3%, but this is at 2017. So if not mitigated, as the authors say here, this absolutely could threaten humankind's survival. And I'm not being hyperbolic, I'm not being dramatic. This is testicular dysgenesis at a populational level. And males, are given no tools. So it's not even really that known, or no one knows to really actually test for it. And these males, they're wondering why they're depressed. They're wondering why, they're getting mixed messages about what masculinity is, and it's a mess. It's a mess. And this isn't comparing to the mess that females experience too. This is just, it's just as bad. It's just different. So early onset, low testosterone in adolescents and teenagers, we're seeing more and more of this. So we call it, early onset hypogonadism versus late onset hypogonadism. So EOH versus LOH. By the way, alcohol, EOH, that's not that alcohol, it's not that EOH, but EOH is one of the worst things for male health. So doesn't mean you can't do it, but just a little tidbit there. Some of you might just click out now and I don't want to hear that. But yeah, when you're trying to get healthy sperm, alcohol is probably the most direct poison that you can put in your body. So other than drinking glyphosate, maybe it's right up there, about the same. So testosterone levels are significantly lower. Same same kind of study, but focused on adolescents here. Factors contributing to decline include obesity in young, poor nutrition, stress, exposure to the endocrine disrupting chemicals. We're seeing a theme here, right? So just another study showing the same thing. Proportion of men with low T in 2002 was 35%. In 2011, it's 47.3%. And the fastest growing testosterone decline is in younger males. So, and the psychological impact, this can be a whole weekend. The male brain doesn't develop properly without testosterone, both in utero and postnatally and in adolescence, and indeed throughout the lifetime. The male brain doesn't work correctly. It's built and meant to have a constant and relatively dependable source of testosterone in order to function. So that means executive functioning and even mood regulation. All of that is testosterone driven. So we see, as an example, autism is 5-to-1 male to female, right? Why is that? Well, it's got to be hormonal, right? It's the only thing that can explain sex differences in between in diseases. And what we're seeing is that in utero, because there's not enough testosterone signaling anymore. I mean, it's due to the endocrine disruptors, due to nutritional deficiencies, due to abnormal sperm, due to egg quality. All of that has an effect. And but endocrine disruptors probably being the number one cause. Then what happens is that testosterone signal gets muted, and the brain, the male brain, at about 8 weeks, 8 to 12 weeks, that's when testosterone levels spike, right? Because before 8 weeks, the male and female gamete is the same, but then, the Y chromosome kicks in and testosterone increases, and without that testosterone signal, the male brain cannot develop, and the female brain needs testosterone too, which is why it's 5-to-1 male to female, and females still get it. This isn't the only cause of autism, but it's just one factor in why we're seeing so much, so many psychological problems with males, and this isn't just neurodiversity, people, and this isn't to say that neurodiversity is bad. Neurodiversity is good, and some level of neurodiversity has always been a part of human history and human evolution. But this type, autism is not a strategy by our genes to survive. So this is a signal that something is off in the environment. Yes, autism has always been around, most likely, but I would say it was more genetically driven, 1,000 years ago than it is now, which is environmentally driven. So, and I go all into that in my classes too. So, we know how to prevent autism, almost 90%, and it starts in utero, because the dominoes of disease begin. The dominoes of childhood and adult diseases begin in utero. So, testosterone and depression, systematic review, low testosterone, because that's not there, drives depression in males. Strongly associated with fatigue, low motivation, irritability, and even suicidality. So that this is something that the male brain is uniquely susceptible to. Okay. So what is going on? We've defined the problem, and if anyone just take a deep breath, where it's not all doom and gloom. We've defined the problem. It's a serious problem. We've established that. So let's dive into what we can really do about it. This is real. So the root causes, as the picture here shows, two main causes that I'm going to say here, not the only, but we've got the chemical environment, and we've got the chemicals in our food and the type of our food. Certainly these are two of the main drivers and the easiest leverage points for us, I think, as clinical practitioners. So we want to become experts. But the environmental factors is real. Endocrine disruptors, you get fetal androgen deficiency, as I just laid out, low testosterone production, blockage of androgen receptor, and even mutation of the androgen receptors. You get impaired androgen effect at the tissue level, and then you get anti-androgens as well, and other endocrine disruptors such as dioxins. And here we have now, more cryptocortism, hypospadias, which is disorders of how the male reproductive system functions. So the urethra pointed in a different direction, the short anogenital distance, and then as you get older, poor semen quality, low adult testicular hormone levels, testicular tumors. Meanwhile, this is all existing in the same environment that produced the problem in utero in the first place. So this is just another picture's worth 1,000 words. Phthalates and, soy products, alcohol, processed foods, sugar and fine foods, and then you get obesogens as well. I put this picture here because a recent study came out showing that the plastics and chemicals inside of underwear, men's underwear, female too, is actually a pretty significant source due to proximity, right? It's something that the testes rubs up against every day, all day, and so I've always had, the last 15, 20 years, make sure that my underwear is either made out of organic cotton or bamboo, and it's organic, and there are Under Armour makes this deodorant type of, or anti-perspirant, deodorants embedded in. These are chemicals that are embedded into clothes and into the underwear and into the shorts and stuff like that. What are we doing? These are chemicals that are driving right in you might as well just spray Roundup right on your gonads, but this is what's happening. So being able to think about this and educate our patients becomes really, really important. Okay, so and this is the countdown. This is the book called Countdown by Shauna Swan. Approximately 8 weeks after conception. Again, that's what I was saying. And these alterations are profound and permanent. Okay, so I really like this book. It's on Audible too, if that's your thing. But this is someone who's dedicated their life to studying this, and many people. I've met many of them. They were kind of my heroes. I read Our Stolen Future in like 2010, 2009, and it changed everything. It changed what I did in my practice. It changed my focus. I was always into hormones. I was a naturopathic. I went to naturopathic school and also got my naturopathic endocrinology certification through the National Institute of Endocrine Research. So this is something that I've always seen as important. But that really solidified that, oh, if we're going to treat hormonal problems, we should, and we call ourselves functional medicine practitioners, and we pride ourselves at getting to root cause. Well, the ultimate root cause is in utero. So I hope all of you are inspired today to learn more about this, and you can take some of my classes. I have a YouTube channel. You can just Google Dr. Brandon Lindell, and I've got some free videos on it. But really, take some of my classes, take my certification course. I also have a mentorship course that will guide people through all of this. So one of the things that in teaching functional medicine, what I've come to recognize is that a lot of doctors, a lot of practitioners out there, you have a lot of knowledge, right? All of you wouldn't be here if you didn't have enough knowledge to know that you wanted to be here. So more knowledge isn't necessarily what people are looking for, what is necessarily needed. So about 3 or 4 years ago, well, 5 years ago at this point, I realized that what doctors need, what practitioners need, is more of an internship and mentorship. That's what we don't have in functional medicine. What do you do with this knowledge? What do you do with the patient? What are the protocols that actually work? Where do you start with somebody? How do you implement this in your practice? How do you train your staff? How does all of this work, and how can you make this work at a clinical level? So I've started a mentorship. And I do a 6-month mentorship with just about 15 to 20 docs. I keep it small because we do small group classes and we do one-on-one, where I get to see where your gaps are and what you need to actually implement this stuff. So I'm starting a new cohort. I'll get to this at the end, but I'm starting a new 6-month mentorship intensive in April 9th. So if any of you are interested, you can go to my website, you can get signed up. We have a few spots left for this next cohort, but only a few. So if you are interested, let us know right away, and we'll make sure that you get in. So because more knowledge is important like this, but how do we implement this? So but I do recommend this book for sure, full of exposure to phthalates and full fat dairy foods and then low fat dairy foods, and what do we really do with all this information? Even over the counter analgesics such as ibuprofen and acetaminophen is tied to if you're both a male and female is using that during the preconception and certainly the prenatal period. Tylenol became really popular in its correlation with autism. Correlation is not causation, but understanding the mechanisms, you can see why Tylenol is just another endocrine disruptor that affects oxidative stress and fetal development. So this study, paternal exposures to endocrine disrupting chemicals induce intergenerational epigenetic influence on offspring, meaning that a single hit, get this everyone, if you're off zoning out right now, tune back in, a single hit of BPA can last 3 to 5 generations. The effect that it has on our gene function, human studies, as well as animal studies. One hit, one exposure to BPA can last 3 to 5 generations, okay? Even if the future generations were never exposed to something like BPA, okay? This is why we have to change it now. We have to be really, really diligent. Endocrine disrupting chemicals and the impact on male reproductive health, phthalates, metabolites are detected in greater than 75% of Americans. Children have 2 to 4 times higher levels than adults. In utero, when studies that look at amniotic fluid, 2 to 5 times higher levels in amniotic fluid than in male or female blood. BPA detected in the urine of 90% of subjects, pregnant subjects in the US, Germany, and Canada. The NHANES study from 2013 to 2016, men in the highest quartile of urinary phthalate metabolites had 12 to 15% lower sperm counts. BPA itself is linked to 10 to 15%. So what do we do? It's not getting any better. We can keep going into this, but we all know this. One of the things that I like to do, and we have many studies on this, and we'll get to a few. It's not about living in a bubble. Yes, we want to reduce and eliminate where we can. I've given podcasts and I talk about creating healthy homes. Healthy homes are really, really important. What can we do? Simple things like replacing toxic carpet. You don't have to gut your house to make it a healthy house. Making sure you have air purifiers, water purifiers. There are things you can do immediately to reduce the load. We use Healthy Indoor Air as our air purifier. It's called Healthy Indoor Air, the deluxe air purifier. You can do reverse osmosis as long as you add back in the minerals. There's lots of ways that you can reduce those exposures. Carpet's probably one of the most unhealthy things. The beauty products, all of that. We can go on and on. But there's also things that we need to do because we can't avoid them altogether. And NAC is one of my favorite things. I take NAC every day and have for 20 years almost. I'll dose up sometimes and I'll dose down, but at the very least, I'll take about 500 milligrams a day. There are times when I'm traveling or times when I'm maybe doing a project around the house or something and getting exposed to things that I'll take 2,000 to 4,000 milligrams a day for a short period of time. But this is just looking at NAC as an antioxidant, an antitoxin, okay? It's a glutathione precursor, as we know. It's a thiol-based antioxidant, and it protects directly. It protects sperm and the DNA. So in this meta-analysis here, the role of NAC orally daily on the sperm parameters and serum hormones in idiopathic, meaning, the practitioners are idiots. No, I'm just kidding. Or the researchers are. Idiopathic means what we're talking about. It's not a disease, but it's environmental. Idiopathic infertile men. Systematic review and meta-analysis of 3 randomized controlled trials. All patients received about 600 milligrams a day, so not a lot. Sperm concentrations. I'll kind of put this in perspective. 25%. So just in 3 months, and just taking 600 milligrams a day. 25% increase in sperm concentration, 28% increase in ejaculate volume, 17% in sperm motility, and 56% increase in normal morphology. And this is just 600 milligrams a day. Other studies that have done 600 milligrams 3 times a day actually show even better benefit. Now, importantly, no significant hormonal changes. Okay, so this tells you that the testosterone problem or the sperm issue is not just a testosterone issue. NAC works obviously via the antioxidant and reactive oxygen species pathway, not direct endocrine modulation. Now, NAC is still important at increasing testosterone levels long term and protecting the gonads and protecting the receptors, all of that. But without changing the blood levels, you dramatically increased how testosterone actually functioned in the body as well. So another study, the effects of N-acetylcysteine supplementation on sperm quality, chromatin integrity and level of oxidative stress. This again was 600 milligrams, and all of the sperm indicators increase, especially the protamine deficiency, okay, which is how the sperm creates its protective layer. So MDA, which is a pro-oxidant, significantly decreased, and the total antioxidant capacity increased. And sperm are uniquely vulnerable because the membranes are 60% polyunsaturated fatty acids, so DHEA rich. So that tells you probably another intervention, right? Fish oils, DHEA, EPA, very healthy for the sperm because sperm is very rich in these polyunsaturated omega-3s and other monounsaturated and polyunsaturated fatty acids. So NAC beyond just motility, it protects DNA fragmentation. It supports this protamine packaging, which is critical for DNA condensation and protection, and it reduces all of these oxidative markers. So that's, we know how glutathione works. One thing I want to say about glutathione and N-acetylcysteine is, because I can already hear a question out there, well, what about glutathione? So glutathione is an extra, when you take glutathione, it's a large molecule, and it's a very potent antioxidant, and it's got a half-life of minutes, within hours in the body. So it's great for detox, protecting maybe cell surface receptors a little bit. But where we want glutathione the most, the 95% of glutathione in the body is inside the cell. So when you take glutathione, there are no receptors for glutathione to get inside the cell. You get a very little bit, less than 1%, might get passively, into the cell. Most of it is just used as an extracellular antioxidant. Well, there are a lot cheaper and a lot better ones. What you want is glutathione inside the cell. And the only way to drive up, the only proven way to drive glutathione intracellularly is with N-acetylcysteine. It's the best way. There, milk thistle and vitamin C and other antioxidants can do it by glutathione sparing. But the only way to drive glutathione production is with N-acetylcysteine, somewhat with glycine, and somewhat with glutamine as well. So that's what we want. We don't want to take glutathione necessarily. I mean, I'm fine with that, but I actually don't use a lot of glutathione in my practice because it's expensive, it's short-lived, and I might use it while I'm traveling, or if I'm getting exposed to something, or if my patients are getting exposed to mold or something short-term, sure, that's fine. But remember, really, it's more like 99% of your body's glutathione exists inside the cell. And when you take N-acetylcysteine exogenous, or when you take glutathione exogenously, you really aren't driving up intracellular glutathione very much. A little bit by sparing, but not very much. So NAC also induces our own SOD and catalase peroxidase enzymes to make that. It increases NRF2, which is your master transcription factor for other antioxidant defenses. So N-acetylcysteine is my go-to. And typically I start with a little bit higher doses because everyone's toxic and we want to use it for other things. So the minimum dose is 1,000 milligrams, and I like to do 500 milligrams twice a day. I've got a great video on how to take supplements and how to get the most out of supplements, timing wise and biphasic nature of supplements. So you can go to my YouTube channel and you can sign up because I'm always giving videos out. I am always a proponent of taking things twice a day because it increases the area under the curve. When you take things just once a day, you get a spike, but then it goes down. When you take it twice a day, you get another spike, and you almost double, or actually you more than double the area under the curve, right? Versus taking 1,000 milligrams all at once, you might get a little higher spike, but you still get then, the other 16 hours of the day where you don't have any in your system. So lots to go over. Okay, we are getting close to the end of part one. This is why we have it in two parts. So I do want to talk about the gut gonadal connection and so maybe another 10 minutes, and then I'll stick around for some questions, okay? But this gut gonadal connection, this gut gonad axis is critical to understand. The gut testes axis is a real thing. The gut ovary axis, the gut, we know the gut brain axis and the gut adrenal axis, but the gut testes axis represents the communication pathway through which the intestinal environment influences the reproductive function. So same mechanisms as the gut brain, the interleukins, the cytokines, the lack of short chain fatty acids, lipopolysaccharides increase, all of that dramatically affects gonadal. But it does seem that the male, the testes, is particularly vulnerable to the leaky gut and intestinal permeability axis. Lipopolysaccharides, because sperm is so rich in the polyunsaturated fatty acids, lipopolysaccharides kind of rip through sperm production. So the microbiome in the gut has a dramatic effect on the quality and production of the sperm. The potential influence here on this study, the potential influence and intervention measures of gut microbiota on sperm. It is time to focus on the testes gut microbiota axis. So, it's not just me saying this. This is something that in the last couple years is gaining a tremendous amount of understanding in the research community and in the functional medicine community. The gut microbiome not only affects the testes, but also the hypothalamus pituitary axis as well. Short chain fatty acids are tremendously important for testicular function, gonadal function, ovarian function. So, and as well as the hypothalamus and pituitary. So short chain fatty acids affect LH and FSH as well. The gut microbiota metabolites, such as hydroxysteroid dehydrogenases in the gut as well. So metabolites produced by the host, modified by the gut microbiota. So you get your gut microbiota here, and it produces the amino acids, indole derivatives. So your tryptophan and tryptophan and also kynurenine. These are all important for the hypothalamus pituitary. The production of short chain and polyunsaturated fatty acids, your bile acids, hydroxysteroid dehydrogenases can greatly affect how, remember number 8 and 9 in the functional endocrinology, the biotransformation and elimination, and also our ability to absorb vitamin K, vitamin D, the production of lipopolysaccharides. All of this is gut driven and very, very important to understand. Lipopolysaccharides, as I said, stimulates interleukins and tumor necrosis factor alpha that directly affects sperm and testosterone production. And this is a great study, mechanisms of male reproductive sterility triggered by dysbiosis. So this is real. These are a lot of studies that are coming out. Here's a normal intestinal microbiota, and you've got good balance of inflammatory cytokines, but here you get more nitrates and beta oxidation and abnormalities in your nitric oxide pathways. So all of this is showing how it affects male reproductive function, sperm, and the brain and all of that we've talked about today. So oxidative stress, immune modulation, regulatory of sex hormone signalings. So many studies have shown probiotics, prebiotics, symbiotics, even fecal microbiota transplants have reversed low testosterone and reversed low sperm counts. So not that that's something that you want to do as your first line of therapies, but fecal transplants, I love it as a therapeutic proving tool because changing the microbiome in a very significant, very short span of time, you then can sit back and look at everything that the microbiome actually influences. You can reverse insulin resistance and diabetes with fecal transplants. You can reverse infertility with fecal transplants. Now, there's other ways to do it, which we'll talk about. But I love the FMT studies in terms of proof of concept studies and showing that yes, this is what changing the microbiome actually does. So It's just another picture there of all that. So there's this gelding concept. Gelding is, a male horse that's been castrated. So this author cleverly wrote the gelding concept of male infertility, the gut endotoxin leading to a decline in gonadal function. Quite clever, I thought. A novel theory for the development of late onset hypogonadism. Not just in obese men, as we saw, though. It's not just in obese men. That was her original theory, Tremelin, but it's much more than in obese men. So this gelding theory links the gut inflammation and testosterone crosstalk. And obesity and poor diet alter gut bacteria composition, and then these changes compromise intestinal barrier integrity. And it's a feed-forward loop because testosterone in and of itself, low testosterone, well, let's say it this way, testosterone and other hormones are required for normal intestinal permeability. It strengthens the gut lining. So without testosterone and estrogen, or too much cortisol as another example, that's the endocrine influence on the causative factors of leaky gut and intestinal permeability. But then you get intestinal permeability, which then causes more lowered or altered hormonal function, which then causes more leaky gut. And that's the same with the inflammatory mechanisms as well. Inflammation begets inflammation begets inflammation. Then you get more lipopolysaccharides, more endotoxins, more inflammation. And again, we're seeing it even in healthy men, relatively healthy men. So this is just kind of a schematic of exposure of the testes to these endotoxins, activates interstitial macrophages, which inhibit steroidogenic enzymes in the Leydig cells, and you get the endotoxins in the hypothalamus pituitary axis as well, inhibiting the release of LH. And this is what we see. We see low LH with low testosterone, which then tells you that part of the problem is in the hypothalamus and pituitary, right? So if it's just low testosterone but high LH, then you know that at least the brain's picking up on the low hormone signal and it's trying to compensate. But in many of these men, that's not what's happening. It's a global decrease in hormone signaling. So yeah, the testicular microbiome too. Emerging research suggests that even the testicles themselves harbor their own microbiome. The testicular microbiome appears to be dominated by the actinobacteria, Bacteroidetes, Firmicutes, Proteobacteria, and it reflects exactly the microbiome that's in the gut. So you change the microbiome that's in the gut, you change the testicular microbiome as well. So, and of course, the more dysbiosis and more leaky gut you have, the more likely there is to be dysbiosis in the testes too. Because those bacteria are getting in systemically. So the bidirectional relationship there. The effect of testosterone. So when men take testosterone, it temporarily improves their gut microbiome, temporarily. But guess what? Because the testosterone receptors downregulate, because the causative factors of the gut dysbiosis was not being treated, it's a very temporary effect. But it does show you that normal testosterone levels are critical for maintaining healthy microbiome. So what do we do? So ProDiof or BioDof 7 is a great probiotic, and biobiotics. We also do, the prebiotics, a lot of fiber in the gut. Sometimes I will use, and I'll do more. We'll go more into this in part 2, so don't worry, I'm going through this pretty fast. But why is your gut microbiome a male hormone organ? That's what you have to think of it as. Okay, ruminococcus is the strongest positive correlation with testosterone levels. The probiotics that are in the BioDof 7 increase ruminococcus. Testing levels. I just gave a webinar at Doctor's Data about testing, GI testing, and which tests to do, and testing your short chain fatty acids is absolutely critical, because temporarily, if you need to take short chain fatty acids like butyrate, it can be tremendously helpful. Lowering lipopolysaccharides, short chain fatty acids in and of themselves increase sperm counts and testosterone levels. So this connection between fiber in your diet, which increases good bacteria then increase short chain fatty acids. All of this produces healthy testosterone and sperm. So regulating the gut barrier integrity, modulates the HPG axis, reduces insulin sensitivity, insensitivity, increases insulin sensitivity, and is highly anti-inflammatory. We'll talk about the estrobolome. It's not just about women. We'll talk about that next time. I like biofiber from Biotics. It has organic flax seeds, and we can see what it does specifically for male health. It modulates estrogen metabolism, supports favorable testosterone to estrogen ratio. It's very prostate protective. Alpha-linolenic acid provides anti-inflammatory omega-3 support. So the biofiber we use a lot as part of my male hormone restoration, gut restoration. So if you are interested in getting, skipping ahead to March 25th, if you email me, I will give you my male hormone support protocol. Okay, and it's got the biofiber. What do I use? What supplements? What diets? What are those? So the male fertility and male hormone support protocol. If you want to email me, just go to drbrandonlundell.com. Contact us through our contact form, and I will send you my male hormone, and we'll go over it in March 25th. But some of you want to go ahead and learn a little bit now. But biofiber is a big part of that. It's got broccoli sprouts, fenugreek fiber, which is great. It's the only ingredient with direct randomized controlled trial evidence for increasing free testosterone in men. So it's one of my favorite things that I use. So biofiber complete. These are just some of the references just for the biofiber. Butyrate is another one that I use a lot, the butyric CalMag. So we'll go more into how this can affect the gut testes axis. Butyrate's dual mechanism of testosterone synthesis as well as spermatocyte protection. So, okay, now I'm just going to skip ahead here to the end because we'll have a lot more to talk about. But I just wanted to let everyone know here that you can go to Nutritional Pathology Institute, my website, Dr. Brandon Lundell. So you can contact me at drbrandonlundell.com. This is my mentorship program that we're doing in April 9th, okay? You get one-on-one with me every month. We do 2 small group sessions every month. And I make sure that by the end of that 6 months, I have a 95% success rate in taking all of the mentees and dramatically improving not only their clinical outcomes, but their confidence. Some doctors have, one doctor reported a 5,000% increase in just 6 months in the patients that they're seeing and the supplements that they're able to provide and their clinical confidence. So it's not just about more information, it's about how to use the information in your practice. So come learn from me. I've been doing this. I'm not in an ivory tower. I'm not a research. I don't just do research. I do tons of research, but I'm in the trenches every day, and I have been for 20 years. So I know what works. And I think that's what's different than a lot of other programs out there is, they kind of realized, a lot of teachers out there, practitioners in functional medicine realize they can make a lot of money just teaching, and they lose their clinical edge. But I'm in there every day. In fact, I'm going to go see a patient in an hour right after I'm done here. So it's sponsored by Biotics, by Doctors Data, by Professional Co-op. So you actually get an immediate $1,500 in bonuses. You get free lab tests, and we get free stool tests from Doctors Data. We get a free hormone test from Doctors Data. We get half off some tests from US Biotech, like organic acids and things like that. Professional Co-op provides LabCorp testing an entire Lundell panel for free, which is about a $450 value. So just by signing up, that covers about half the tuition. So You can either do monthly payments. All of this is online. You can go to my website, Dr. Brandon Lindell. Let us know because it is filling up fast. I also have a one-day seminar that Biotics is also sponsoring, March 28th. This is my annual functional medicine practice accelerator. It's my chance every year to kind of go through the latest of what I've been studying and implementing in my practice. This one we're going to go more into fertility. We're going to do peptides, how to implement peptides in your practice, and why, most practitioners are doing it, I wouldn't say incorrectly, but they're certainly not getting the most out of peptides in their practice. So we're going to teach you how to optimize that. And we always keep it affordable. Everything we do is about keeping it affordable. So for $199, you're getting 8 hours of top-notch functional medicine education. So hopefully you can join us there. And this is just some of the things that we will cover. This is also on my website. So again, a good doctor knows what to do. A great doctor knows why. I thank Biotics Research for partnering with Nutritional Pathology and myself, Institute and myself. This is a partnership that's really here to advance your knowledge, your implementation, your understanding of functional medicine, and how to do this in a way that really makes sense and really is effective. So, so thanks for having me. I hope to see everybody March 25th and March 28th and April 9th. So you can get as much of me as you want. But I'll stick around for a couple more questions, Sally, if you want to stick around.
Oh, yeah, well, thank you very much. I think we're well over our time, but I will look forward to March 25th for sure. This was incredible. So many, we did have a lot of questions. And actually, if people want to direct those questions to Dr. Lundell directly at his website, or you can email us at communications@bioticsresearch.com, and we'll forward those. And of course, as we mentioned, part 2 of this series will go live Wednesday, March 25th. And we'll also include in our follow-up email today a recording of this webinar and some information with links to Dr. Lundell's other seminar and courses. So on behalf of Biotics Research, thank you so much for being with us today. And we look forward to seeing you on March 25th. Have a wonderful day.
All right. Thanks. Bye, everybody.